Good afternoon and welcome to the American College of Surgeons Inspiring Quality in Surgical Healthcare Forum. I'm Dr. Stephen Johnson, President of the Arizona chapter of the American College of Surgeons. I'm a trauma surgeon, a general surgeon, and I'm also proud to be the program director of the Phoenix Integrated Surgical Residency, which has provided Arizona with a large number of its surgeons. We are here today to embark on a discussion addressing a critical issue in healthcare, nationally, regionally, and in the state. Amidst the national dialogue surrounding patient access to health insurance, surgeons and healthcare providers must continue to focus their efforts on ensuring that the delivery of patient care is the highest quality possible. We are here to ensure that the discussion about healthcare reform addresses the quality of care being delivered. Because any discussion on healthcare is ill-conceived without emphasizing the importance of quality as a driver. Our patients expect it, our surgeons advocate for it, and our healthcare policy experts know about it. Complications drive healthcare costs, and if productive discussions are to be had about reducing costs or expanding our coverage of patients with restricted funds, we have to have these discussions about how to improve the quality we are providing and the value our patients are receiving. I am confident that unlike some of the discussions about health care in our country, our discussion today will be very productive and not lead to a widespread shutdown. Quality, what is it? It's easy to mention, it's difficult to define. But to be effective at providing high-level quality, we need to define it, we need to measure it, we need to report it, and we need to collaborate to improve it. And we must do so with the leadership that understands the importance of the bedside and the impact on the patient. Only at the bedside can the quality be defined and the quantifiable impact that the patient experiences be better understood. Our forum today is intended to explore and provide dialogue on the important issue of quality and the challenges we face specifically in the state of Arizona. We have an excellent panel who will bring their expertise to focus on this topic and lead the discussion. Our intent is not to provide just words, but to provide deliverable paradigms and actions that will improve the quality of health care delivered to the Arizona's surgical patients. Our panel includes our keynote speaker, Representative Dr. Heather Carter of District 15. We're honored to have you here. We're also honored to have Dr. David Hoyt, who is the Executive Director of Surgeons. Also notable in our panel discussion is Dr. Stuart Flynn, Dean of the College of Medicine, Dr. John Hensing, Senior Vice President and Chief Medical Officer of Banner Health, Leila Barraza, Adjunct Professor of Law at Arizona State University and Deputy Director of the Healthcare Policy Institute, and Dr. Nirav Patel, who is Vice Chairman for the Quality and Patient Safety at Banner Good Sam Department of Surgery, and also the Chairman of the Arizona Chapter's Committee on Quality. We'll begin our discussion with Dr. Hoyt, who will frame the issue of quality surgical care and provide proven methods for improving it. Dr. Hoyt.
Well, good afternoon, and I want to start out by thanking Steve for putting this together. These are a lot of time and effort, and it's really wonderful to come into a community and have a conversation about quality, and it takes a leader, and Steve, thank you for that leadership. What I'm going to do with you is kind of frame how this got started and where we've been going with this. And we just celebrated the 100th anniversary of the American College of Surgeons. And when we look back and ask ourselves, what are we about, we came up with this concept of the Inspiring Quality campaign, because truly we feel that we have the opportunity to live our values of commitment to quality, but also inspire others, particularly at a time when healthcare reform is so daunting. Now, it's easy today to be cynical. We know that quality is critical to patients, to providers, to payers, and to cost effectiveness or profitability. But too often, we've seen quality that has been temporary in fixing something become transient. But we've learned that with best practices, you can, with the right tools, make quality stick. And I want to show you some examples of this, and that's probably what will frame a lot of the discussion today. Now, historically, this just shows the programs that we've been involved with. And many of you may not know, but in 1917, the American College of Surgeons, under the leadership of Dr. Codman, set the standards for hospital care at a time when surgical care in hospitals was very unsafe. That ultimately became the Joint Commission, which spun out of the American College of Surgeons. But our heritage has been around this principle. We subsequently developed the Commission on Cancer, which creates cancer standards for cancer hospitals around the country and now the world, trauma centers in 1950, and more recently, bariatric surgery centers, breast centers, and the NISQIP program have really joined this group of programs that are focused on quality. When we consider those programs and ask ourselves, what is it that we've learned from this? There are really four principles, and you've seen them articulated, and they're in the little cubes that we've passed out. I want to spend just a moment going through these because I think it's very important as you think about what can you do in a system or as principles. The first is that by patient type, whether it's a trauma patient or a cancer patient, a bariatric surgery patient, set a set of standards by which you think that patient should be cared for. It should optimally be backed by research when available or consensus when not. It should be nationally benchmarked. And that standard setting process is step one. The second is then to commit to the build out of the actual program, and that has implications for the specialty mix, equipment, the use of checklists, information technology, etc. And it's what we spend a lot of our time doing when we decide to build a particular kind of program. The third is really important, and that is at the get-go, at the beginning, realize that you have standards that you're putting forth, commit to the measurement of performance against those standards by having a data system that will allow you to judge whether you're achieving those standards, and if you're not, what the problem is, and how to then go about fixing it. And ideally, this needs to come from medical data, from charts, not from really administrative data. And I'll show you some data to suggest why that's important. And then fourthly and finally, verification. Subject yourself to external peer review. We've done this as a tradition in surgery for just individual cases, but this really says that if you build a trauma center or build a cancer center, that you're willing to allow yourself to be critiqued from the outside. This, if you think about it, really is the way we assure the public that we are doing what we say we're doing. It is truly a good housekeeping seal of approval type entity. Principles, we made a decision about 2.5 years ago to go around the country and engage sessions. This just shows you the list of places that we've done this. And it includes most of the large cities in the United States, and this year we have another from that, is really 6 principles. That is the future of medicine. And I think and it's not easy to measure, but it is measurable. Thrives in a supportive culture, and it's imperative for leadership in terms of trying to move the needle. Collaboration helps with spurring innovation and higher quality, and collaboratives across systems, within systems. We have good evidence that helps improve quality. And then finally, surgeons have got to be involved in surgical quality, whether it's in the operating room, in the classroom, or on Capitol Hill. Now, this is actually perfectly aligned with what's going on at a national basis. If you look at the National Quality Strategy put forth by Secretary Sebelius 3 years ago, the emphasis on better care, healthy people and communities, and affordability is completely aligned also with the triple aim, which Don Berwick put forth when he was CMS administrator, to improve the experience of care, the health of populations, and reduce per capita costs. And finally, the Institute of Medicine in the last 5 years or so has really looked at a learning healthcare system as the ultimate goal for what we should be doing in healthcare reform, and it really is based upon continuous improvement. And in fact, if you use these 4 principles that I've talked about and the lessons that we've learned in going around the country, you actually do create a continuous loop, you do achieve high quality, and you do achieve this goal of a learning healthcare system. So that's really the basis upon which we'd like to start the conversation today. Now, said a lot simpler and maybe even more right if you go to the words of Ernst Codman, who's shown here with the first registry ever developed in the United States. This was a sarcoma registry developed. We should do it just because we can. And that may actually be the most important message we agree upon. Now, the program that I want to tell you a little bit about is called the NSQIP program. It's a registry and quality improvement program for general surgery and vascular surgery. As I said, we have programs in trauma and bariatrics and cancer as well. But the concept of this started in the VA at a time when they were having trouble with variability in their care, and Congress basically created a program to try and improve that. With that program, there was a 27% decline in postoperative mortality, an improvement in morbidity, length of stay changed from 9 to 4 days, and patient satisfaction improved. And if you looked at those metrics, you might think that that's something that a healthcare system would put out today. And in fact, this was put out in the late 90s. Based on the success of that program, we got a grant from ARC and asked the question, can you move what has worked effectively in the VA system into the private system? And that's when NSQIP was born in October of 2004. Today we have about 500 hospitals. It includes most of the major surgical procedures of the significant severity in the country, even though obviously there are a lot of hospitals that are not participating. What's different about this is that it's developed by surgeons. It uses clinical data, not administrative data. It's risk adjusted. It uses national benchmarks, and it has 30-day patient follow-up. The data is collected by a trained collector, and the collection process is actually audited. So this, as many will say, this is the real deal when it comes to data collection. It's the only thing that might be superior to this would be research data in some clinical trials. What you get is this graph, and this is not to oversimplify all the reporting capability, but I want to just spend a moment on it for those that don't do this every day. For the surgeons in the room, they know what this is, and this is the performance against some outcome in this orange line. This could be DVT prophylaxis, this could be surgical infection rates. And when you profile yourself, in this case against other hospitals, this could be individual providers, you have some that are out here on the right in red that are not doing as well as everybody, and some in the green on the left here that are doing better than everybody. When you give this kind of data to surgeons, the needle moves. The people over here don't want to be there. They're dissatisfied with that. If they're a hospital, the CEO says this is not good. They share this data internally, and they do something to actually move. Much of what they do is to study what the people over here in green are doing so that they can get into this middle zone. And in fact, we now have pretty good data that in fact happens. This is a study done by Cliff Coe and Bruce Hall about 3 years ago that looked at the first 300 hospitals and found that 82% of those decreased complications by implementing these programs, decreased mortality, and it worked out to about 1 complication prevented per day per year. And if you think about that, that's realistic. I mean, that's something you can actually believe in a 300 or 400 bed hospital. Now, why clinical data? And this is a very important study that it actually was co-sponsored by CMS. And they allowed us to compare the pickup rate of complications with the NSQIP data set and the CMS data set on the same patients for the same hospitalizations. And you can see for yourself that if you don't use carefully collected data, you miss complications. If you're looking at this from a negotiation standpoint of a bundled payment, that's going to be a concern as well. But mostly, you really don't know about problems you can't see. How do we then bring this and cost reduction together? And in fact, just to show you a very simple algorithm, if you accept the fact that a program like this can reduce about 1 complication per day in a large hospital, and an average complication price is about $11,000, then you're talking between $3 and $5, $6 million savings in one hospital across all the hospitals in the United States. It's a significant cost reduction. And this is a real contribution that this kind of commitment to quality can make to this cost-quality argument that we're having in Congress. Now, when you work with other hospitals, this even gets more interesting. And here's a collaborative where all the hospitals in Tennessee, 10 originally, now 21, have collaborated and used the same thing. They've reduced a number of complications and saved a tremendous amount of money. So this is real. It's been repeated time and time again, and it's really why we're trying to share this with everybody. Now, it's not just a database. It has to be a culture. And you have to get that right. And for the leaders in the room, you all have, I'm sure, considered this a lot. You can't have a blame-free culture. You can't have a punitive culture. You somehow got to get into this middle zone where people really take responsibility, and leaders are becoming clearer. It needs to be patient-centered. There needs to be a leadership commitment. Safety, transparency, and performance improvement needs to thrive. And again, in fact, our concept of professionalism is really changing from collaboration, evidence, and measurement basis with transparency. In fact, professionalism really is becoming accountability, and that's what we need to commit to as we go forward. Does it work? The buzzword today is a high reliability organization, and again, a commitment to improve performance using simple techniques applied in a standard. You can get feedback, and then accountability to performance, and the bloodstream infections associated with central lines by almost 50%. And I would argue that that's a very good paradigm for how we approach all these in medicine going forward. It's so important that we're in the process of putting together a book called The Resources for Optimal Quality of Surgical Care. We may at some point actually even offer a program to hospitals to assure that the quality that's occurring in their hospital is on a par. I want to just leave you with the way that we have looked at this is that this was initially a campaign about inspiring others to try and commit to this. And when we ask ourselves, why is this? We really came up with the word driven, is that it's because we're driven to do it. It's really like Ernst Codman was 100 years ago. And this little video just sort of sums it up. Again, thanks, Steve, for letting us be with you today.
Thanks, Dr. Hoyt. That certainly was a great way to frame it and inspire us to know why we're here and what we're going to be doing going forward. Our keynote speaker today is Representative Heather Carter, who is currently in the 51st Legislature of the Arizona State. She's represented from District 15, which represents Northern Phoenix, Cave Creek, Carefree, and Scottsdale. She's also the chairperson for the Committee on Health of the state legislature. And she is focused on a number of issues related to health care and has been the sponsor of several bills and legislative endeavors. She's an important champion for health care policy issues. She's also a clinical associate professor at ASU's Teachers College. She has her PhD from Northern Arizona and has been a instrumental force in the changing of education here in the state as well. So, Dr. Carter, we welcome you to provide your insight in how the state and Arizona can benefit from this.
Pause for, make sure this is still on. Can you hear me? Can you hear me? I'll put this up a little higher. Actually, I'll probably just hold it. It'll be easier. Well, good afternoon. And once again, my name is Heather Carter, and I am the state representative from District 15. So thank you very much for having me here today. It's a true honor to be here with such a prestigious group, talking about some of the most important things that we need to be talking about today when we're working with our healthcare leaders. This is a little bit about my background. I think you got a gist of it in the introduction. As an aside that I like to mention, technically I am a teacher doctor, and technically I spent, let's say, about 1.5 years as a pharmaceutical representative, so that makes me infinitely qualified to be the House Health Chair, right? Well, I say that jokingly, but in reality, since we are a citizen legislature, we each bring our unique talents and skills to the Capitol to do the best work we can for our state, but there really aren't a lot of medical professionals serving. Right now, technically, we have 2 physicians in office, one in the House, one in the Senate. And if you think about the 90 people that make important decisions for our state, having only 2 physicians on our legislative body sometimes can create a challenge. So today, if you take nothing away from my talk today, I want to make sure that you know that you are invited to come down to the Capitol, and I hope you get engaged in public policy, because we really do impact your field. And so if we don't hear from you and we don't know what your concerns are, we don't have your great ideas, we need to make sure that we're basing our policy on the best medical information that we can. So with that, I'm going to just give you a little bit of a framework of my role here today and kind of frame it into 2 words, politics and policy. And so when you really think about it, the skills that make you an effective politician, so in my case, I have to be elected to this position, are unique and different, extremely distinct from the skills that make me an effective policymaker. Now, if you think about it, as a politician, to be able to get reelected, I have to be able to talk in 8-second sound bites. I have to be able to knock on the door, establish a relationship, and talk somebody into voting for me in a very short window of time. That's very different than the work I do at the Capitol. When I'm handed a bill, in the case this year, which I'll talk about in a minute, our Medicaid restoration bill, well over 200 pages. And so what you have to look for when you're working in the policy arena, as medical professionals, you spend the majority of your life over in the policy world, but you need to understand the political world in which we live, because that's how you're really going to make a difference and an impact as medical professionals to make sure we're making the best policy decisions. You've got to help us frame it into what's good for the citizens of Arizona. So today I wanted to give you just a little bit of a preview of what's coming in the legislature next year, where we were last year, and then also what has led us to this point. And I don't think anybody in this room would disagree with me when I say that the Affordable Care Act is fundamentally driving health care in today's society. And so it's a really complex policy. It has been passed by Congress. It was upheld in the Supreme Court. President Obama was reelected, and I believe that now we have to figure out the best way we can be successful and provide high-quality care to your patients. And as a state lawmaker, I don't necessarily work with the entire components of the Affordable Care Act. But as a state policymaker, we fundamentally had to make a decision. So Arizona was the last state to join the Medicaid system nationwide. And that's typical. Arizona kind of likes to do our own thing, chart our own course, and that's what we did with Medicaid. But I'm here to tell you that what we did in Arizona was absolutely right. It was before our time, and now we are the gold standard across the country for how to deliver health care in the most cost-effective and efficient manner possible. It's a managed care model. It's a public-private partnership. And what a lot of people don't understand in Arizona is that the patients who are, their payer is Medicaid, they're seeing the same doctors, they're going to the same hospitals that you and I would be going to as private pay, as cash pay, as a Medicare pay. And so our system in Arizona is a very complex system of payers. This is not the case across the country. Some other states, and for good reason, have decided not to expand. They have a system where they have a government-run healthcare. The government, the state government, actually owns the hospital, for example. That's not the case in Arizona. So it's really unique, it's different, it is the model, so much that even in the last presidential election, on a debate non-related to healthcare, that Governor Romney quoted, and he said, "Let me give the money to the states like Arizona and Rhode Island. They've proved that they can do more with less and do a great job with it." I'm paraphrasing, but that's what he said. So as we're looking at what was happening in Arizona, specifically, we covered childless adults. And before I get into what we did related to our childless adults, I want to talk to you a little bit about the hidden healthcare tax. In Arizona, when we had an economic crisis, the likes of which none of us had ever seen in our lifetime, we had to freeze our childless adult population. What resulted from that decision is that a lot of patients showed up in the emergency room. And I'm sure, if I see people shaking their head in the audience, you guys have seen this in your hospitals. And what happens is, as you know, related to federal EMTALA, you can't turn them away. But obviously, hospitals are not going to do their work for free, right? Somebody's going to pay. Well, who pays? Obviously, you and I pay as privately insured people or cash people, or costs get shifted to a variety of sources. When the chamber looked at this in Arizona, and they looked at the financial impact of our decision to freeze the childless adult population, we realized that we were shifting a hidden health care tax onto all of the other payers in the system. These are the numbers at the systems level, but on the individual level, it's about $2,000 per family. So this is a really complicated slide. I actually teach computer literacy at ASU, and if one of my students put that slide up, I'd fail them. So let me do the best I can to explain it. The blue and the dark purple, sort of dark blue bars are all of the populations that are automatically mandated by being a part of the Medicaid system. We have to cover as a state. We don't get to decide. They're already in access in Arizona. The part that is in red is our childless adult population, specifically the bar to the right. Under the federal poverty level, we believe that these people should have health care insurance. So the Arizona voters twice voted to cover this population. This is long before President Obama was in office. This is long before the Affordable Care Act. This is long before any of that. So the Arizona voters decided this is good public policy, health public policy. So they passed it. That's the population we froze. So we were looking at a budget decision this past year of what are we going to do with this population? At the high water mark, we had over 1 million people in the system. But as we froze that population, the childless adult fell off the roll. So if they were still eligible and they maintained their status and access, they could stay on Medicaid. But if for any reason they became ineligible, like for example, they got a holiday job and worked during the holiday season, and they made $50 more than what they needed to make, they were no longer eligible. So they fell, quote, off the rolls. Or, and here was a really, really important population, are persons who suffer from severe mental illness. Unfortunately, a lot of that population ends up incarcerated for a variety of reasons. But once they transition out of the Medicaid system and into the Department of Corrections systems, they lose their Medicaid. When they are released from either jail or prison, they're no longer eligible. So that was a large number of people. It was over 10,000 people. And so I can talk to you about all of the populations that fell off, but at the end of the day, there were at the high water mark of just the childless adult population. And right now we're looking at by the end of this year that there were only going to be 60,000 people on those rolls. So we had to say, what are we going to do with this population? Well, what we did was we decided that we would draw down additional federal dollars using the Affordable Care Act to cover that population, and it allows us to take our federal match from 67% to 85% if we slightly expand our eligibility to 133. So that the people between 100 and 133 are 57,000 people. So a lot of times in some states, because they didn't cover their childless adult population prior to the Affordable Care Act, you're talking about a large number of people, hundreds of thousands, sometimes pushing 1 million people. That's not the case in Arizona. The expansion population, of which the federal government pays for 100%, is 57,000 people. The remainder of the population of the childless adults was the population that the Arizona voters, long before the Affordable Care Act, said we needed to cover. Another piece to this policy that we put forth was the hospital assessment. The hospital realized, look, even though I know Medicaid may not be the best payer, some money is better than no money. And so they said, you know what, we're going to step up to the plate and we're going to be a partner in this solution with the state of Arizona, and we're going to allow you to assess us, and it's a complicated formula. They've already launched it. The hospitals are fully engaged with this, and we are going to assume the general fund responsibility, the state match for covering the population moving forward. And so they've stepped up to the plate, and that will be rolling out January 1. At the end of the day, my role as a state legislator is to produce a balanced budget. I can pass all the bills in the world, but that's not part of my constitutional job. My constitutional job is to balance the budget. And this was by far the most fiscally responsible thing that we could have done for our state. So it was House Bill 2012, it was ability up to 133%, but we put in there an ironclad circuit breaker that if any pieces of the Affordable Care Act are either changed, the federal match drops below 80% or is repealed, then we are automatically repealing our policy that we put forward, including the hospital assessment. So remember when I talked to you about politics? That's what it looked like. Can you find me up there? I'm up there. I'm actually riding a miniature horse because I had another bill this year that talked about miniature horses as service animals, but I won't digress. So needless to say, it was a very contentious legislative session. I believe that moving forward, we are still facing a contentious legislative session, but the Republican legislators that voted against our Republican governor have sued the governor by name. And so this session is going to be extremely contentious. That being said, my message to all of my healthcare stakeholders that come down to the Capitol is I'd probably just take a deep breath and sort of fly under the radar for at least 1 year, but we will probably continue to have conversations about things like graduate medical education, the medical board. I don't know if you're following the paper, but the medical board is a big, big issue. We will be having a committee meeting actually in 2 weeks on that. We're going to talk about some scope of practice issues, and of course, always talking about cost saving and preventative benefits. But really, it's going to be more of a defensive year this year, just kind of saying we're not going to, we did a lot last year. Last year was probably one of the most influential legislative years in terms of healthcare policy in the last 30 years. I've only served 3 years, so to go through that on year 3 was pretty monumentous. I believe the work that you're going to do here today is really important with that bullet point about cost saving and preventative benefits, because I'm not the medical expert. You are. And I'm going to tag on to a little bit of what you said in the presentation prior to me. administrative versus clinical metrics. I mean, we really need to be looking at the clinical metrics, but I'm here to tell you a lot of times we in the legislature look at the administrative metrics. So the more work that you can do to communicate that with us, the better. And with that, an open invitation to visit me at the Capitol. Our healthcare committee meetings in the House are Wednesday morning, in the Senate are Wednesday afternoon. We're in session starting the second Monday in January, and technically we go 100 days. So we are in session usually until about the end of April, 1st of May. So thank you for having me here today, and I look forward to the rest of the conversations.
Thank you, Dr. Carter, Representative Carter. That was excellent and really frames the issues that we have at hand here in the state of Arizona. I'd like to invite up at this time our panel. We have a notable and noteworthy group of individuals who bring unique perspectives to this issue of quality as it relates to Arizona. Dr. John Hensing is an internist by training, but is responsible for being the Senior Vice President for Healthcare at Banner, as well as the Chief Medical Officer. Next to Dr. Hensing is Leah Barraza, lawyer. She is a Deputy Director for Law. She is an adjunct professor. Dr. Stuart Flynn. Dr. Flynn is an expert on the training and education of medical students and also residents into the future. And next to him is Nirav Patel. Dr. Patel is our Vice Chairman for the Patient Safety and Quality at the Banner Good Samaritan Medical Center, and also the chair of our Quality Committee for the American College of Surgeons Arizona chapter. Each of these people brings a unique perspective, as well as provides us a framework for which we can have further discussions, and we'll have each of them take a couple of minutes to talk about their area. Dr. Hensing, will you lead us off, please?
Thank you, Steve. I'm very pleased to be here today. Thank you, Steve, for inviting me. I wanted to have everybody notice that I'm not a surgeon. And the reason I'm saying that is because one of the things that I wouldn't want to do at an American College of Surgeons meeting is tell a surgeon joke. So I had another one I thought I'd begin with, and I'm sorry, Leela, if it's going to touch your profession. But I heard this just a couple of days ago, and I thought it was worth sharing. How do we know that God was a lawyer? Well, she also began with darkness and chaos. We in the medical profession are thankfully not struggling with darkness and chaos. I think the presentation by Dr. Hoyt on what the American College of Surgeons is pursuing is admirable. Hats off to the American College of Surgeons to bring that professional society, which has influence beyond probably what you fully understand, amongst essentially every specialty in medicine, is incredibly helpful to those of us on the front lines trying to, in fact, improve clinical quality and excellence in outcomes on a regular basis. I'm going to give you, and my assignment today from Dr. Johnson was to spend a little bit of time talking about the business case for clinical performance and clinical excellence. We're a large health system here in the state, and we have, in fact, we're in 6 other states. We have 24 hospitals. We take care of 240,000 inpatient cases a year. We deliver 5 kindergarten classes every day because we have 32,000 babies that come out of our hospitals every year. We do 140,000 surgeries, inpatient and outpatient. We have 2.8 million outpatient visits to our medical group. So that if we as an organization can improve clinical outcomes, the scale that we can reach, and the scale that all of you can reach in your institutions, is very substantial. I would argue, in fact, that everything that I'm going to walk you through, and it's just 4 key points that I want you to remember, are influenced by you, influenced by professionals, influenced by essentially every healthcare professional group, but particularly by physicians and surgeons who interface with the other professions on a regular basis. I'm going to divide these 4 areas of challenge into a simple mnemonic, QRST. This profession and this industry is in the middle of the most transformative time in my career, and almost certainly in yours. I think Dr. Carter walked us through some of the political complexity in the Accountable Care Act, but there are other influences. QRST, Q stands for quality and reliability. Dr. Hoyt referred to that as well. Quality is becoming very transparent. It is going to be a key measure, along with the service provided to our patients, that they will be judging us at an individual hospital level, health system level, physician and surgeon level. The amount of information that they're going to be able to seek on the website, on the exchanges, before they plunk down their hard-earned money paying for premium, is very substantial. That transparency is real. Additionally, we're not the same profession that we were 25, 30 years ago when I was in training. The complexity of this industry and our profession is much more vast. Each of you can prescribe 7,000 different drugs in the United States. Each of you are theoretically licensed to provide 6,000 different surgical procedures. There are 14,400 codes, diagnostic codes in ICD-10. This is an incredibly complex delivery challenge for all of us, and we're going to have to do this together, and it's going to take clinical leadership to do it. Reliability is not something that the healthcare professions are known for. There are other high reliability industries that Dr. Hoyt was referring to, the same rate of an error every 100 to 1,000 exposures. And if there was any other industry in this country that was performing at that level, we would not participate in it. We certainly wouldn't get into an airplane. We wouldn't even mail a letter. We simply have to increase our level of reliability. R, and I've already referred to this, refers to retail. The retailization of healthcare is real. The exchanges are already open, although not working, but they're open and they're going to be working. And the exchanges that we're seeing are not just government sponsored. There will be private sponsored insurance exchanges. S is for safety. There's very clear evidence that we harm patients every day in our hospitals. There's no question healthcare delivery is dangerous and provides excellent outcomes in many circumstances, but safety is an issue. And finally, T. We are in the middle of a business transformation. This process where, and I've described this very briefly, this process where in the 1960s and 70s, healthcare was financed through insurance. It was an insured era. The advent of Medicare, Blue Cross Blue Shield came together in the mid-1980s. In the 80s and 90s, we were in this era I would describe as managed care. Sort of classic, distant nurses in call centers trying to manage what happens to members of their health plan. And we have moved now, particularly in the last several years, to an accountable phase in our healthcare financing. And that means that the shifting of the responsibility for clinical outcomes is moving from the insurance companies and the purchasers, whether governmental or commercial, to provider organizations, to medical groups, and to the patients themselves with health plan designs, including high deductible plans and so on. The accountability for clinical outcomes is ours. We own it, and really rightfully so. Every other industry is not reimbursed for their costs, every other industry lays a guarantee, so to speak, on the quality of their service that they provide. We are in a position to solve the QRST by virtue of actions that we as professionals take. We own this. The American College of Surgeons has been a strong leader, I think an incredible leader in making that happen. Dr. Hoyt referred to a systematic approach and an acceptable culture. A systematic approach allows us to be reliable, to get the results in a very consistent way over time. Two quick examples that I wanted to give you a sense for that have actually happened inside Banner, and they have a surgical bent to them. One of them is, and also kind of keying off some of the comments that he made around collaboration, you really can't do this until you get clinicians together in a room, look at data, look at performance, look for opportunities of improvement. We had one group of surgeons that got together and looked at some of our data regarding our total knees. Total knee arthroplasty, common procedure, about 3,000 to 4,000 are performed inside Banner every year. And they noticed that if we didn't put those patients who did not have a Foley catheter placed were 5.9 times more likely to be ambulating on the day of surgery. Those same patients were also, that were able to ambulate on the day of surgery, had 2.9 times more likelihood of ambulating more than once on post-op day number 1. Now that seems pretty simple. Don't put a catheter into somebody and ambulate them. Ambulate them on the day they have their operation. And the outcomes of just those two simple things done in a highly reliable way to the vast majority of patients with total knee replacements in our hospitals resulted in, and it's actually approved or accepted for publication, it resulted in an 11% reduction in complications, a 19% reduction in readmission rates, a 10% reduction in direct costs. About $1,000 per case was saved by simply not slipping an indwelling catheter into them and getting them out of bed on the day of surgery. It didn't cost us anything, but we've now got data, practice patterns of orthopedic surgeons to accomplish that. Another example, and then I'll finish because I don't want to run out of time, and that is this whole concept of safe surgery. You folks have been leading this effort. We brought in a cognitive psychologist from the University of Minnesota to help us design an acceptable way to address how are we going to make sure we don't do wrong site surgery? How are we going to make sure we don't have a retained foreign object left in the body of a patient who's having surgery? Two simple things happens commonly in healthcare, happens at Banner. We were able to reduce our retained foreign site surgery over the last 2 years since we implemented our safe surgery program at every one of our hospitals. We were able to reduce the incidence of those two challenges by 47%. And if you look at it from a liability exposure, complications, and long length of stay, one of our process engineers calculated that saves Banner over the next 10 years $78 million. Safe surgery makes a difference. Physician leadership makes a difference. Consistent approach to complex problem solving makes a difference. We as a profession own it. We have the best opportunity of our careers to, in fact, take on that responsibility. Again, kudos to the American College of Surgeons. Thank you very much.
Thank you. And I want to specifically thank you for inviting me here. I'm obviously the odd one out on the panel, the only non-physician, the only lawyer. So I wanted to thank you for including a lawyer on this panel to represent some of the changes that are coming and have already actually started under the Affordable Care Act. I'm going to highlight a timeline of some of the most instrumental changes under the Affordable Care Act, the changes to healthcare that have started or are coming in the future. And then I'm going to finish with some specific quality measures that have pilot programs or other programs that are targeting quality measures in hospitals, in doctors' offices, specifically to improve quality improvement. First, I want to mention I work for the Network for Public Health Law, and if you ever have any questions about this presentation or about public health law in general, we are a Robert Wood Johnson Foundation program housed at the College of Law at ASU. It's a national network, and the western region of the network is housed at the ASU Tempe campus. We offer free legal public health assistance. So you don't often get to talk to a lawyer for free. We don't offer legal advice, but if you do have any questions about the Affordable Care Act or anything in your own practice, we answer questions for doctors and hospitals all the time. To start with the Affordable Care Act, year one, in 2010, 2011, we expanded coverage for children up to age 26. We started with the rejection of pre-existing conditions for children. The law required that no policies be canceled, stopped lifetime or annual limits, started a Medicare donut hole rebate, and gave small business tax credits to provide insurance. In year two, there was free annual wellness visits, so no cost sharing, a fee imposed on drug makers, brand name drug discounts for Medicare, home care for the disabled, and we had underserved areas practice bonuses. Some of the heftier changes now, we started standards for electronic health data exchange. There was a limit on flexible spending accounts. There was also a threshold change to medical tax deduction. It used to be 7.5%, now it's 10%. It's still 7.5% for if you are over 65 until 2016, but for the majority of the population, it is now 10% of your adjusted gross income. There's also an increase in the Medicare hospital insurance tax. For income over $200,000 for a single person or $250,000 for a married couple, there was a 0.9% increase in the payroll tax for Medicare. And there's a 2.3% excise tax for medical devices. In our current year, year 4 of the Affordable Care Act, starting soon, we will have enrollment in that health insurance exchanges, hopefully soon, and the programs will all begin next year. We have no annual caps on benefits soon, and no coverage of pre-existing conditions starting in 2014 as well. The employer mandate, as most of you know, was delayed till 2015, but it was originally intended to be in this year 4 component of the law. And starting next year, individuals must purchase private health insurance. Now, also in fiscal year 2013, we have quite a few quality measure programs targeting payments to hospitals through the Medicare program. The first one I'd like to highlight is the these all have really long names, I don't know why. The Hospital Readmissions Reduction Program. That's a program in which Medicare payments will be withheld from hospitals if too many patients return within 30 days for 3 conditions. And the 3 applicable conditions are acute MI, heart failure, and pneumonia. Excessive is going to be rated by a ratio. It's going to be a ratio of the predicted readmissions for those 3 conditions divided by the expected readmission rate for similar hospitals, for an average hospital with similar number of patients. Now, if the ratio exceeds 1, that will be considered excessive. And that's when hospitals will start to see some penalties as a result. Medicare identified 2,225 hospitals who, starting October of this year, 2013, were subject to the penalty. 18 of those were going to lose 2% of their Medicaid funding, which is the maximum penalty. The maximum penalty will go up to 3% in October of 2014. So these penalties are just continuously going to get worse, with the hopeful incentive that the hospitals will improve their programs to reduce these readmissions. The second one I'd like to highlight is the hospital value-based purchasing program. And in this case, hospitals are rewarded. They're rewarded based on how closely they follow best clinical practices and how well hospitals enhance patients' experiences of care. So the incentive payments to hospitals are based on how well they perform each measure or how well they improve their performance. So it's either improvement or existing status quo, how they're doing, performing each measure. Another program is the Bundle Payments for Care Improvement Initiative. This was effective of January of this year, 2013. This is another program that will affect hospitals, and it bundles payments into an episode of care versus a single payment for each procedure or aspect of a procedure. So for example, if a patient was receiving a heart bypass surgery, that would be an episode of care, and a payment would be received for that specific one episode. And this program was implemented to improve coordination of care. The goal was to provide better coordinated care to lower costs, unnecessary repeat procedures, and to reduce medical errors. Those are the goals of the hospital, the bundle payments for hospitals. There are some upcoming programs too in fiscal year 2015. This is, you may have heard of this one, it's been a hot topic. It's the payment adjustment for hospital-acquired conditions. The goal of this one is to reduce hospital-acquired infection rates. So hospitals that score within the top 25% for the rate of hospital-acquired conditions compared to the national average will have their Medicare payments reduced by 1% for all DRGs. And 1% may not seem like a lot, but obviously for a hospital that could be make quite an impact on the money they receive from Medicare. And you'll probably, since that one is fiscal year 2015, you'll probably see some more of that in the future, some more rules and regulations outlining how exactly that's going to happen. There's one other aspect that I wanted to focus on is the accountable care organizations. This is a new model that is developed under the Affordable Care Act and intended to improve quality. It's intended to coordinate care. It provides incentive for doctors and hospitals and businesses, for example, Walgreens, or pharmacies, to join together and coordinate and provide high-quality coordinated care. From the legal aspect, it's a legal entity. It's a separate legal entity with its own taxpayer identification number. And these organizations, these legal entities, will provide care to patients. If they provide care and meet certain quality benchmarks, they can share in the savings costs that they save for Medicare. So some of that savings from Medicare will come back to these organizations, and that's the incentive. There are certain requirements. The ACOs must manage a minimum of 5,000 Medicare beneficiaries. They must have sufficient participation of primary care doctors. They must develop processes that promote evidence-based medicine and have a shared governance for caring for beneficiaries. They also must report on quality and costs. And they must coordinate care across multiple areas. And this will hopefully provide a coordinated unit. There has been some negative ideas about what could happen with ACOs. Some people are afraid it'll be similar to what happened with some HMOs, or that large hospitals will overtake physician practices and will limit patient access to different doctors. But the goal is to coordinate care and improve care, obviously. We'll see how that, a lot of the big entities are just starting with this, so we'll see how this plays out, hopefully in the future. The last measure I'd like to discuss under the Affordable Care Act is was already been mentioned in Dr. Hoyt's speech. It's the National Strategy for Quality Improvement in Healthcare. It's a report that under the Affordable Care Act had to be developed by the Secretary of Health and Human Services. It was published in 2011, and it involved a wide range of stakeholders: patients, payors, clinicians, hospitals, businesses, a wide-ranging group. And the collaboration is supposed to continue into the future. And this report was intended to guide local, state, and national efforts to improve the quality of healthcare. And it included 3 specific aims: better care, healthy people and communities, and affordable care. And those were the goals to achieve through this report. It is, if you're interested, available online through the Agency for Healthcare Research and Quality at www.ahrq.gov/working-for-quality if you're interested in reading the report. I admit I have not read the whole thing, so I don't know how exciting it is, but I do recommend that if you're interested, you go check it out and read it. In conclusion, I'd like to mention that there will be a lot of change in quality, I think, under the Affordable Care Act, because the Affordable Care Act was intended and intends to fund quality improvement. And I hope that in the future we do see a lot of these programs being quite successful to improve care for our patients, for your patients, I don't have patients, but for your patients and for the community at large. Thank you.
Thank you very much. It's obvious why we asked you to participate. That was an excellent overview of what's going on now. Our next speaker, Dr. Stuart Flynn, is Dean of the College of Medicine here at the University of Arizona, Phoenix, and an educator at heart, a pathologist by training now.
Well, I've been asked to talk about medical school curriculum, which is usually not a topic that keeps people in their seats very long. So, but what I would really like to impress upon you is this topic, how absolutely serious we take this at this medical school. So I will give you a little bit, thank you, a little bit of an overview on this. So the good news for those of you who have gone to medical school, you're not paying tuition for this talk. This is just the absolute job of a lifetime. The average longevity of a dean is a little under 3 years. So I wake up every day and I embrace this job. I will just tell you that much. These were the 3 talking points I was asked to talk on. And so you'll see the role of the faculty in training on areas of quality improvement. And I've just highlighted the faculty are the role model that our students see. What's the importance of involvement in health policy and health economics? We, the physicians, need to understand this. We need to lead this. What are the challenges and the opportunities in refining medical school curriculum to address quality assurance, leadership, healthcare economics, and you could append more to that. First of all, we have to embrace its importance, and then we have to engage. So I'd like to spend a little time telling you how we're doing this. So I put in bold here, this is the definition of quality from the IOM. And I put in bold, I just highlighted a few parts of their definition, and then beneath it, comment on where we try to interface with this definition. So certainly precision medicine, which is a buzzword these days. We have an entire, when we talk about improved desired health outcomes, we have an entire theme that transcends 4 years in the domain of public health. So none of our students gets out of this college without being quite facile in that domain. Everything is evidence-based medicine. When they come to anything, we ask them to deal with evidence-based medicine. Technology in medicine. We have a beautiful sim center here, but that's just the beginning of the technology. That's not where it ends, that's where it starts for our students. And cultural competency. That's the area we need some work. So we have designed a theme for this, for our curriculum. These are teaching moments for the next generation of physicians. And we just call it, it's a healthcare transformation theme, part of the buzzword and topic that we're hearing here. It consists of scores of hours curriculum. In other words, it's not a soundbite in the translational moniker. Instead of from laboratory to bedside, it's from classroom to bedside. And I highlighted 2 of the 5 themes to this today: quality and patient safety, advocacy, and leadership. So I put this entire slide, I'm not going to read it, you're not going to read it, but I thought to do justice to the seriousness of this for us. And then I've just bolded a couple flashpoints for your eyes to land on. So our students will address performance measure use, patient safety, care transitions. And as I was going wild with my cursor, bolding things, I almost bolded the whole page, and then I knew I couldn't do that, so I backed off again. So there is a lot of substance in how we bring this to our students. And to show you some of the ways we do this. So these are small group sessions. So this is just the template for a small group session. So we ask our students to describe a sentinel event, and then you can see they go down the entire their entire process here. So it's as though they're sitting over at Banner, but they're sitting in the cloistered, pristine world of a medical school where it hasn't counted that there was an adverse event, to make them, again, more robust in being leaders in this regard. And to go to Dr. Hoyt's comment, if you notice number 6, we apply just culture to this. We want this embedded in how they're going to practice medicine with their teammates for the rest of their career. Here is another example of how we address this with our students. Again, I'm just giving you what is the template for an interactive session, or how we ingrain this into our curriculum. And this is another, the quality improvement cycle assignment. So they go through this process, identify their team champion, find the root cause of the quality issue, and bring it all the way down to the bottom where you study your results and decide on the actions for the next cycle. So we want to have our young women and men who go out into residencies and practice, and if they should stay in the state of Arizona, and if they should stay in John's system, we are hoping that they will be primed to interface with exactly what John spoke with, rather than the system having to spend a great deal of time to bring them up to speed. We view that as our job. So we put something in front of them to highlight this is real for them. This is what their career is going to look like. So the things that were just spoken about by the other panelists, we want them to understand this is the environment they're entering into. So quality does matter, and they're accountable for the quality. Their recertification absolutely matters, and so they will stay on top of these things. So just to segue to the end of this, physicians as leaders. This was one of the questions asked of me, very topical. And again, medical schools like this are training the next generation of physician leaders. So when I gave some thought to this, I thought, what are the motives for a leader to be a leader? Now, I actually had an applicant to this medical school who I spent time with, who told me his goal, career-wise, was to become a dean. And I'm just going to just let that stay. But motives for leadership, so aspirational, inspirational, new challenges, and guess what the most common one is? Happened up in this leadership role. So we would like to prepare our students to be leaders. Which of those 4 or others? We want them all to have exposure to elements that improve their leadership qualities. And at the end, because, and this is a quote, the welfare of patients, the education of students and residents, and the growth of research knowledge are commitments underlying our profession. And I don't think you will find many in the medical profession that will tell you that we don't need physician leaders and we need more of them. There is a void in this arena. So this is, again, I highlighted part of the element of our curriculum in healthcare in our healthcare transformation theme. This runs for 4 years, just to say it again. So when our students arrive, we start titering this into their curriculum. And they spend 4 years. So this is not a half-a-day seminar in and out and they're done with healthcare transformation theme. But you can see some of the bullets that we touch on. The culture of medicine, which we all know, we live in it. So you have to know the culture, and then we have to decide which elements are we going to try to perturb, bend, or even grossly change. Introduction to team dynamics, facilitation of conflict management, participation in policy making process, decision support. We have a very strong interprofessional education curriculum here where we work closely with the U of A College of Pharmacy, ASU's nursing school, ASU's social work school, and in discussions with others, as well as the U of A nursing school. So this is a great opportunity to work in a delivery system as a team, not as individuals, and to work with your professional colleagues. Again, for those of us a tad older in here, it begs the question, was this how we were trained in medical school? Every one of our students does a 4-year research project and writes a thesis. That is a lifelong learning component that builds leadership with what they do. Community outreach, I would love to have spent the 12 minutes just on this to tell you what these young people do and give back to our community. And we have many, many more opportunities from which they avail. So, and we've now in the process of finalizing a certificate in leadership. So this is above and beyond. So we have a certificate in leadership in outreach and community. We have a certificate in outreach and community. We have a certificate in rural health, and we place the value on this. We have a certificate in leadership. And you can see what some of the themes are that these students will be exposed to, even at a greater level than the rest of their medical school colleagues. And it runs quite the gamut, and yet it's very easily defensible why these are all important. And last slide, I thought real hard what to put up here. So these are 2 seniors from this school. I'm pretty comfortable they are going to do something beyond profound in their careers. I just hope I'm around long enough to see what they do. I think they may do it pretty quickly. And I could have given you many examples of a lot of students. But these 2 young men went out very quietly and entered the competition for Google Glasses. And they won. And they got to go to San Francisco, and they got all kinds of really cool things. But they came back with these glasses. They couldn't wait to meet and start figuring, where can we use Google Glasses when they actually become commercially available in our curriculum? And so we, again, have spent hours and hours and hours with these 2 young men. And so when these become commercially available, again, not because they're a toy and not because they're contemporary today, they are powerful. If you haven't seen how they work yet, certainly in the clinical realm, there are already several clinical arenas where these, but we're looking at these right now purely from an educational domain. So these are leaders. These are our students, and they are going to be national leaders in what they do. I'm comfortable with that. So on that note, I apologize for talking about a medical school curriculum, but I just wanted you to get a little of how we address issues very germane to the ACS and to the next generation of physicians. So thank you.
Thank you very much, Dr. Flynn. That's obvious that the students of the future are going to be better prepared than we were by the curriculum such as this one. Our next speaker is Dr. Patel. Dr. Patel will be taking and bringing this conversation, discussion down to the level of the practicing physician.
Good afternoon, folks. Like Dr. Johnson said, my stand here is to be one of the grassroots people. We're the ones who live this every day. A lot of times we don't understand it. You can't walk around a corner now without somebody coming up to you and asking you why you didn't comply with X, why you didn't do Y, what happened with Z, and you're looking at them going, really? But what exactly do you want me to do? Why am I doing this? And you've heard a lot of it today with our panel. This, unfortunately, is this whole issue of what is quality. Dr. Hoyt touched on it a little. We've heard it from a legal, we've heard it from a legislative perspective. The problem is we're all in the same boat. We're looking at the same thing from multiple different angles, but at the end of the day, the outcome is the same. But all these processes are what is going to mold that outcome. And that's where we, as surgeons, have always been part of it. We're type A's, whether we like to admit it or not. Something tells you did something wrong, you want to know why. You want to figure out how you can do it better. You find out somebody else did it better than you, game on. That's not going to happen because I need to be on that caterpillar curve that Dr. Hoyt showed. We want to be on the far left. Nobody wants to be on the far right. And so I think if we look at how we're wired to make this happen. We always have been. It's coming from the medical student level. It comes into residency. It comes into practice. But unfortunately, the realities of quality change as you transcend across that spectrum. They're all different. But if you look at quality and say, what is it? What constitutes quality? And if I look at it from a perspective of being a provider at the bedside, I think it's based on stakeholders. We're different. The patients are looking at it different. Then we have the healthcare providers. It's just not physicians. It's not surgeons. Environmental services, all the way to the physicians and medical staff. It has to do with healthcare organizations and systems. We heard Banner's perspective. There are multiple healthcare systems out there, and they have a stake in quality in terms of outcomes. It has to do with dollars and cents. We're in a business, and that business has to make money. It's not going to happen overnight. And then you have the whole legislative part and the regulatory part of things. There are people telling you what you need to do, how you need to do it, what you need to accomplish with it. And then the question comes full circle, and you've heard a couple of offers here of having open door policies. Come in, tell us what you want, tell us what you do. And part of our problem is we do a lot, but we just do it. We don't knock on doors. We don't let people know what we do, what we need. Just suck it up, make it happen. That culture's got to change. And that's where this whole issue of quality and this whole new spectrum of moving into a whole new generation of how we do quality comes into play. What makes us unique in that? We're the only ones, the healthcare professionals, that at any one point in time are going to be one of those four stakeholders. We can be a patient, we can be part of legislation, we can be part of organizational infrastructure. So we're in that very unique position to drive this whole process because at any one point, like I said, we're going to sit in any one of those seats. But if you break them down and take off your physician hat, how do people look at quality? What does it mean to them? To your patient, it means a completely different thing to what it means to you, to what it means to Dr. Hensing when he's looking at the dollars and cents. Is it outcomes? What are we measuring? Are we reducing errors? Are we having never events, as we've been told? There are certain things that cannot occur in medicine, just don't happen. Are we looking at patient satisfaction? Are we looking at length of stays? What exactly are we looking at? If you look at it from a financial stewardess position, are we standardizing practices so we don't have variations in care? We're not getting dinged, as we heard, for readmissions for congestive heart failure, for acute MI. But that's all process. And is it a generation now where, as we look at process, it's not about this is the way I do it, and hence that's the way it will be done. We really have to evolve past individual performance to group performance as well as organizational performances. And that's where this whole issue of we want better outcomes. I don't think any of us go to work in the morning and go, all right, who am I going to mess up today? It's not going to be a good day today. I'm pissed off, and somebody's going to pay for it. None of us go to work to do that. But on the other hand, how many of us show up at work and all of a sudden go, are you kidding me? You want me to do what? You want me to sign what? When? I don't even know why I'm signing this. Why do I have to do this and this? What difference does it make to me? Let me just take care of my patients and let me not worry about everything else. That, unfortunately, reality has changed. We have to be engaged with every aspect of what we do with the care of a patient. Because at the end of the day, that's what the new quality chiasm is all about. It's no longer the individual practitioner. It's how we do this as a group and all the entities that are involved. So that brings down, how do you measure it? Are we measuring processes? Are we measuring outcomes? Are we measuring a combination of the two? We heard a few examples today. And those of you who are surgeons, how many have gone to the operating room and all of a sudden got, seriously, you want me to do a timeout? You want 4 people to tell me the same thing? Can we just get going and get this operation done? It happens in every OR. And then you got the people say, no, you got to do it. It's the right thing to do. You're validating. You're reducing errors. You've got sepsis. Classic example. Now you get sepsis alerts. And if you don't act in a timely fashion, somebody's going to be writing you a letter. That, hey, wait a minute, you identified X, Y, and Z, this triggered, why didn't you act on it? If you did act on it, did you act on it appropriately? Or did you treat sepsis the way you thought it should be treated? That's a whole paradigm shift. We're really moving into an era of accountability. The problem is, as Dr. Hoyt pointed out, how do we know that the accountability that we're being held to has any significant validity to it? We're asked to do a lot of processes. SCIP is a classic example. Do process A, B, C, D, E, because that's what we measure. You don't have a choice. You have to do all this, and you're going to be graded on it, whether you did it or not. And then you sit there and go, how come? Is there any data that tells me that this actually has any benefit to my practice or my patient? Or is this just a thing that somebody thought up and said, look, if you do 1, 2, 3, 4 things, that sounds good. It should have a good clinical outcome. But does it? We all know is not going to translate into good clinical outcomes. But we're held to those. We're held to report cards. We're held to reporting agencies that are looking at what we have. And so if you look at a couple of things, they're very simple. If a patient died, it's binary, yes or no. If a patient didn't maybe die or kind of died, they died. So end of story. You get a yes or a no. And if all of medicine was that way and that's what we were held to, it'd be very easy. It'd be a checkbox. We just do a binary tree and say, yep, yes, no, yes, no, yes, no, we're done. And we find the answer because it's a logistic model. The problem with healthcare, unfortunately, is we're behind industry in terms of how we look at quality, how we look at safety, how we look at outcome. And the problem, though, is with healthcare, we have one unique problem. We're not Toyota. We're not an airplane. We're not a car. We're dealing with patients. And not all of them are the same. You can look at a manufacturing process and say, look, if I do X, and you put part Y in this place, that's the way it should be done every time. Now we're going to measure how often we do it. And we'll measure how quickly you do it. And we'll set a standard for what it should be. How do we do that with our patients? They're all different. They're not all the same. They're not wired the same way. They don't have the same problems. They may have the same diseases, but that doesn't mean that they don't have other risk factors that go with it. So what do we do with that? And how do we try to get around things like that? But that, I think, is a unique challenge. You look at patients, they have comorbidities. So we may fix an inguinal hernia and say it's an inguinal hernia, but there's a difference between a 20-year-old perfectly healthy individual who gets an inguinal hernia and the COPD with congestive heart failure and diabetes who gets it. And then we start comparing surgical site infections and say, your infection rate is high. Yet you sat there and you followed all the processes in history. You have to start looking at data that has validity in terms of what your clinical outcomes are. And that's kind of the 4 pillars Dr. Hoyt talked about. You've got to look at standards. You've got to look at infrastructure. You've got to have robust data. And then you've got to verify it. And I think that's all great. And we definitely need that, and that's the direction we need to move. Because if we look at how we're held to data, and if we look at how we practice clinically, how we set a role model for the medical students, they're not going to be very excited when they come on service and one of us is having a little pissy fit about not meeting a certain criteria and being held accountable to it. We're going to have to look at how we get our data. We have administrative data. We heard about that. It's not all bad. Administrative data is available. It's collected in a very standardized fashion. It's inexpensive because you're collecting this data for other reasons. You're not reinventing a wheel to do it. It's longitudinal. You can link it, which gives it a tremendous amount of power. But the problem is it valid? Is it accurate? Can we clearly base outcome measures on something that is purely administrative? We can't. We can definitely use administrative data to guide us, to tell us where we have problems, to look at the financial aspect of things, to look at compliance issues. It's pretty black and white. Those are all binary things. You can do that with administrative data. When we start looking at clinical outcomes and we start looking at patients, there's this unique population we now have, which is not a machine. It's not something that's all the same. This is where clinical data becomes a huge issue. And when we look at clinical data, it's got to be something comprehensive. It's got to be standardized. If we look at definitions and they're not standardized, how are we going to compare across the board? Because somebody may call X a pneumonia and somebody else will call it something totally different. So what do we know what the true incidence is? We have to have standardization of definitions. We've got to have things that are risk adjusted because that's what we deal with every day. We deal with every patient as an individual. They're not one body. They're all unique individuals with their own problems. We've got to look at whether the data is valid. Is it benchmarked? We may think we're doing a great job. Dr. Hensing may come to us and say, you guys are doing great with DVTs, it's wonderful. And then all of a sudden, he gets a comparative database that shows us to be on the right side of the curve. That's what's going to drive us in terms of where we sit with healthcare. So if I look at it from a grassroots perspective, what I could leave you with, it's a blend. This is a culture that everybody has mentioned, but it's a blend of what we do administratively and what we do clinically. Without the clinical aspect, we can't address our quality and outcome issues. This is not an issue of numbers. It has to do with the patient and the unique medical issues that they have. It has to be a culture of transparency. We can't have any fear of retribution. We can't be living or practicing medicine because we're afraid we're not going to get paid. If we report a DVT, you're not going to get paid. And they'll look at you and say, look, I did everything you told me to follow the protocol, and my patient still got a DVT. So how are you held accountable for that? It's not an absolute science, but the current data that we're using, NISQIP, it's our first step to actually using risk-adjusted, validated data. It's going to allow us to benchmark. This kind of data allows us to have practice patterns, compliances, and you've got data that you can put behind it that people will understand. You can go to your providers and say, look, this is why we're doing this. I mean, most of your providers are reasonable people. If you try to put something down their throat, you're not going to get anything. You put data, valid data in front of them, things that they can relate to clinically, and then ask them to make a change or benchmark them. I think when we look at the culture of quality, we as care providers are going to see a huge impact with improved outcomes and at the same time accomplish the economic goals that we need to. Thank you.
Thank you, Dr. Patel. That was excellent. I'm going to ask Representative Carter and Dr. Hoyt to join the panelists in the front. Let me open this up to questions from the audience. Dr. Dolan.
Thank you. A very interesting discussion on the critical topic, quality, and I think surgery is leading the way. And I just want to put in a little plug for the VA, which started NISQIP over 20 plus years ago and really got the ball rolling for quality measures in surgery. And this is very helpful. It's a complex issue. But one thing I did not hear is I believe that litigation, lawsuits, in our economy. I've read figures 1 to 2% of our gross domestic product, certainly in the private sector, industry area. I know my family's been affected by that very much. In the medical area, we didn't hear a thing about the impact of liability, medical malpractice, and the impact on the whole system. What do all the panelists see as the future here? Because we've heard nothing about it. It's going to be the gorilla in the room, or one of them anyway, and I'd be interested in comments on medical malpractice reform to help improve quality of healthcare in our country. Thank you.
Who would like to take that?
Well, I'll start just from a very brief response and then turn it over to either the lawyer or the doctors up here. We've done some very, what I would call surgical strikes in areas in statute that we can bring about medical malpractice reform, specifically in the emergency room and things like that. But everything that I've looked at from a statutory perspective as a lawmaker, we would have to change the Arizona Constitution. So any major work in this area that would really bring about deep change, good change, like on the scales of some of the things they've done in Texas, would require us to go to the Arizona voters. So if you want to talk politics, there it is. I mean, that would be a political battle like nobody's business, because as soon as you gear up the docs versus the trial lawyers, just take what happens in the court and put that out on TV. You might want to not turn your TV on for a few days when that campaign's going on. But that's what it would take in Arizona to do anything really systemic to make huge changes. We've done so much in Arizona, even long before I started serving, where we can in statute, but it really does take a constitutional change.
Well, that is definitely a tough question. And obviously, years have gone by that people have attempted different methods in different states, different methodologies. Would greatly just reiterate what Representative Carter said there. It really, in Arizona, would constitutional environment. But I guess it could be done, but I think a lot of the message would be that it has to come from the doctors. A lot of the push, I think, there has to be a movement for it. And if there has to be a movement and then a receptive movement as well, there has to be push for it. And I think if there is a push and there is evidence that things can work, I think it could be done, but it would be very tough, I believe, in the current legal environment we have in Arizona. It would be very tough to accomplish currently. Sorry, that's not the answer you wanted.
Dr. Hoyt?
Well, just a couple of comments. First of all, I don't think there's going to be a national solution. And so, what is then the opportunity? And we held a conference about 9 months ago where we brought together a number of experts to explore the different models that have currently been considered as alternatives to the current way we do it. And a couple of things came out of that. One is that the most successful models seem to be in large systems of care, where first of all there's an attempt through the mechanisms we've been talking about all day toward high reliability to mitigate the risk that way. Secondly, when there is an event for which there may be appropriate concern, then to evaluate it quickly and offer a settlement quickly. And when you go through that kind of concerted effort to manage the risk in an organization and not just put the individual provider at risk, then there seems to be a better outcome all the way around. So I think we're learning about it. I think, from the side of physicians, it was discussed by several people today about the importance of leadership. I think we really need to train physicians a little bit differently, starting in medical school, in how to deal with this kind of problem. And if we can actually get people more comfortable with it, then in fact we may be able to choose some of these alternatives. But it really has implications for the curriculum, like we just heard about, which I just think is absolutely wonderful. To start talking about how do you manage risk when you're a medical student, when you know you're going to be involved in it, is new territory, and it would suggest from the results of these systems that have done that it pays off. So in the meantime, I think it's a local state issue, and it's some states have been successful. The most successful ones, though, have evaluated and then managed quickly.
Other questions? Yes.
It's quality improvement is a buzzword around every hospital in the country. The Healthcare Quality Improvement Act of 1986 introduced the peer review process for the first time. I'm delighted to hear that in the peer review, because under the current circumstances, the medical staff and hospital relationship from a horizontal standpoint is changing into a vertical standpoint, because 65% of the physicians are now hospital employees. The other 35 see that some of the peer reviews that are victimizing the ones that are not employed. And I think this is an area where we need to do something about it, because we're talking about the litigation. See if you have to defend yourself in front of the peer review. It's very expensive. And I think that the external peer review is welcome. Any other thoughts on that subject?
Dr. Hoyt, you want to take that in terms of objective risk adjustment as a peer review process?
Well, I think, first of all, peer review has been part of surgical training and surgical culture since the beginning of time. I think it's gotten much better with objective data, and I think risk adjustment absolutely helps the peer review process. But group that's employed, in other words, how do they defend themselves? Yeah. Again, I just don't. I don't think we know. I think you have to have a process in a hospital, and this is actually what we're struggling with in putting the outline for this book together. We did this 15 years ago when we developed trauma systems, and how do you distinguish peer review that's essential for multidisciplinary care from peer review that is simply judging care? And we've had traditions of doing it. I don't know how you do it at Banner, but you probably have a system that's pretty well written down. But the problem is that we want to encourage that, but not make it punitive. And that's where I think we all have got to learn a different way from the way in which it's been done in the past. And so I don't know if that helps. I think the systems that are developing seem to be doing a better job at it, but I think this is something that surgery is done very differently from the rest of medicine, and I don't think it's consistent across the house of medicine yet.
Just a couple of comments. First, I have the distinct pleasure of seeing every serious reportable event that happens inside our organization. And the vast majority of them are really not physician related. That is, they are not related to the professional practice of medicine or surgery. They are more commonly process related issues, and the professionalism of the organized medical staff, whether employed or not, in the vast majority of our hospitals, in fact, is really beyond question. They do a very, very good job. I am unaware, and it turns out that only about 15% of the physicians that have privileges at the Banner hospitals are actually employed. So it's nowhere near the ratio that it applies to your circumstance, sir. I'm unaware of the employed versus the independent physicians. At least I'm unaware of any particular circumstances where that has resulted in unfair peer review processes. I think all of us are working on approaching peer review in a very appropriate fashion, with very much the same way we're doing quality improvement. Very good data, as good as we can get. Strong physician leadership in a very organized and consistent fashion to review the professional practice of every member of the organized medical staff. I think we're actually doing a better than I was in practice a few years ago. And I think that we do believe that there will be a level of responsiveness and other issues that in fact physicians will be held accountable with over time. And I think with some of the curriculum changes that Stuart was talking about, I think physicians will have that same level of expectation of professionalism amongst themselves. We've learned a lot of professionalism and have been exploring it a lot in aviators and how they were somewhat resistant to individual review of how they performed as professional pilots not so many years ago. Now they're also a pretty capable group, highly professionally trained, but they have moved as well to a higher level of comfort about expecting a level of performance and professionalism in the cockpit amongst each of them. I think we're getting there as well. I think we're getting better at this.
Well, and I think specifically for surgeons, the concern is always if somebody has several similar events that suggest that they don't know how to do a procedure correctly. How do you fix that? And I think we're getting much better at starting to understand what the criteria to fix something, what the retraining that's involved, et cetera. And we're getting much more objective then about reestablishing credentialing and competence. But it has not, it's been done very subjectively in the past.
It has been. One of the things that I think has been very helpful to us, and Stuart mentioned this as well, and that is we happen to enjoy a large investment in a simulation capability, both at our teaching hospital downtown Phoenix and as well as a hospital that we used to operate, but that we actually turned it into a simulation facility for nursing training and others. It's less of an issue in a large metropolitan area like Phoenix, but in some of our smaller hospitals where there's only one surgeon in town, he's been there 30 or 40 years, and we're wondering just whether he's really capable of doing some of the surgery he did so successfully 20 years ago. Assessing some of their professional performance and technical competency is something that's much easier to do in an objective, observable environment by his colleagues in a simulation center. I think that'll be something that we'll see more and more of as time goes by.
I think from a perspective of, as you were asking about private practice employed, this is one of the beauties of having these comprehensive clinical databases. There's no bias, they're validated, they're benchmarked. So the surgeons or the medical providers are actually being compared to the cohorts locally as well as across the country. It's nobody making up definitions or attributing complications to individuals. It's a standardized system. And I think as we go to more of the standardized system, these variabilities are going to go away. I don't think it's going to matter what kind of practice you're in. It's really going to be driven by the robustness and the validity of the data.
Okay. Question?
And, first of all, I'm Howard Pitluck. I am a recovering surgeon. But I now work for the Quality Improvement Organization here in Arizona, which I would wager to say most of you don't even know what that is. So quality improvement organizations are mandated by Congress. Every state has one, the QIO. We are Health Services Advisory Group, HSAG. And so as a surgeon, I obviously am familiar with the American College of Surgeons NSQIP program. But before that, there was the SCIP project, the Surgical Care Improvement Project, which came out of Medicare. The Affordable Care Act, as you all know, is really being driven by Medicare, Marilyn Tavenner, and of course, Catherine Sebelius from HHS. But we are the ones, that is, Medicare is the one that is really driving this quality improvement effort. And so really it is very much a part of what's going on. Every topic that was talked about today is something that we work on as a quality improvement organization, which we help all of you to work on. We're free, we're paying for that through our taxes. But specifically, I want to talk about two things. One is somebody mentioned urinary tract infections or healthcare associated infections and the whole idea of using catheters. We've been working on this for 3 years now. And here in Arizona, we've been able to get the catheter rate down, although I will tell you that surgeons are probably the toughest group to, well, maybe not the toughest are the emergency room physicians, but after them are the surgeons in getting catheter rates reduced. Because catheters do cause infections, and catheters cause falls, and catheters cause bed sores. We need to get rid of them. But on a positive note and a successful note, we here in Arizona, when it comes to transitions of care and reducing readmissions, 30-day readmissions for Medicare patients, by way of background, 1 out of every 5 Medicare patients who are discharged from a hospital are readmitted in 30 days. It's 20%. That's the number. So we took it upon ourselves about a year and a half ago as one of our projects is to reduce readmissions for Medicare patients. We did a statewide campaign. It was called the No Place Like Home campaign. I will tell you the results came in last month, and we were able to reduce the number of Medicare readmissions by almost 6,000 in a 12-month period here in Arizona. We are now #1 in the country for reducing readmissions. Arizona, of all places. So quality is important. We all work together. We work with the surgeons. We work with the American College. We work with the American Academy of Family Physicians as well as the ACP. And we are there for you. I encourage you to work with us in quality. We are the Quality Improvement Organization. That's in our name. And we do work with Cliff Co., of course, through the American College as well. So again, thank you for this. And I do have one question for the dean. So did you admit that guy who wants to be a dean? Did you admit him to medical school?
He did, and I'm his mentor.
Succession planning, right?
Absolutely.
Thank you very much to the panelists. Thank you for everybody attending.